PCSK9 inhibitors finally arrived. When and where to start? It's a burning question. We all know that hypercholesterolemia is one of the major risk factors, and the primary target is LDLC level. And it has been proved beyond doubt that lowering LDLC lowers the major cardiovascular events, and therefore LDLC remains the primary target. However, there are limitations. Even after getting optimal level of LDLC with statins, there is a residual risk of ischemic heart disease and coronary events. Even then, some people are intolerant to statin therapy because of adverse effects. Some of the high risk cases or familial hypercholesterolemia, they are there. It is difficult to treat LDLC at optimal level or desired level with a statin alone. So these are the conditions where we still require certain new drugs. And to it, the rescue came with the IMPROVE trial, where the ezetimibe revealed that there is a further reduction of 6% of LDLC when it is added with a statin therapy. And then come a new molecule, that is the PCSK9 inhibitor. And these trials, Fourier and Odyssey, they threw light and they suggested that the LDLC can be further reduced in the tune of 50 to 70%. That's a huge number. So first of all, what is this new molecule? That is the PCSK9 inhibitor. It is present in the body, secreted from the liver, intestine and kidney. It has got a role, and it was detected accidentally in French family and as well as in a girl from Zimbabwe. There was a nonsense mutation that resulted in the very low level of LDLC, that is in the tune of 30 to 40 milligrams. Then the research came from lab to the clinical part. PCSK9 binds with the LDL receptor. It transfers it into the hepatocytes, leads into the lysosomal destruction, and therefore number of LDL receptors responsible for the clearance of LDL cholesterol is very less in the circulation. That is the basic principle. And here they tried to inhibit this PCSK9, and therefore if we can inhibit the PCSK9 inhibitor, if you get a pointer please, then the LDLC receptor will bind to the LDL cholesterol that will be engulfed. LDL cholesterol will go to the lysosome, which will be destroyed into fatty acids and amino acids, and the LDL receptor again is free to go up to the hepatic cell and again fetch new LDL cholesterol. And therefore, if there is a PCSK9 activity is high, LDL cholesterol will be high. If PCSK9 activity is low, LDL cholesterol will be low. These are the various molecules, though there are further other molecules, but these are in the clinical trials of phase 3, alirocumab, evolocumab and bocazinlimab. Now, the two evolocumab and alirocumab, they are the human monoclonal antibodies. They are injected subcutaneously. They are approved by the FDA after studying the first phase 1 and phase 2 trials in 2015. The dose of evolocumab is 140 milligram twice weekly or 420 milligram once in a month. The dose of alirocumab is 75 milligram or 150 milligram in fortnightly or monthly. No dose adjustment is required if there is a mild to moderate hepatic or renal derangement is there. However, there is no data whether it should be used in severe hepatic or renal derangement. These are the various trials. Phase 1, phase 2 is completed. Phase 3 is going on. Results are expected by the end of this year or at the outset of the 2018. It's very difficult when paucity of time. I'm not going to discuss the trials, but major trials where the results are available. Osler, it is a multi-central trial, and evolocumab was compared with a placebo, and the result was encouraging. there was 61% reduction of the LDL cholesterol as compared to the standard care alone. It was not only restricted to the lowering of the LDL cholesterol, all the other atherogenic lipids, they were also having the favorable response with the PCSK9, whether it is the reduction of non-HDLC, reduction of ApoB or LPA, or triglyceride, or there is an elevation of the HDL cholesterol. Then in the phase 3 trial, with the results are still awaited, the CV event rate was remarkably reduced in Osler 3. In this particular trial, the patients were included who were intolerant to the statin therapy, and therefore this was tried against ezetimibe. And again we found that evolocumab was effective in patients who are intolerant to statin therapy. They were getting ezetimibe, and in contrast to ezetimibe, the lowering was in the tune of 51%. This is the Fourier design trial. It is against what will be the major adverse cardiac events if it use PCSK9, because phase 1 and phase 2 trials have proved beyond doubt this is a tolerable drug. It reduces LDL cholesterol up to the level of 60%. And in this, we found that even in reducing the major adverse cardiac events, this trial is showing results. And this was presented in the ACCA in the 2017 and in the ESC Congress in 2017 in the last month. And the reduction is significant in the tune of 15%. Not only diabetic mellitus is equivalent to cardiac coronary artery disease, and the evolocumab has proved beyond doubt that it can reduce all the atherogenic lipid profile in diabetic patients also. And recently, ODC DM insulin trial was shown in the European Society of Diabetes, and there it was found that as against the placebo, as against the ezetimibe, it has got a distinct advantage in lowering LDL cholesterol. Now the evolocumab ODC group of ODC trials are going on. Long term, it is evaluating the safety. Again, the LDL cholesterol reduction is the tune of 61%. Now the third molecule, bicogecomide, it is still not approved by the FDA, and unfortunately, the trials Aspire Heart HF, HR, LDL Aspire 1 and 2 in the phase 2, they have been halted in 2016 by the innovative company, that is the Pfizer. This was because of the LDLC lowering was there, but the adverse effect was too much as compared to the evolocumab or the evolocumab. Now here I am going to say what are the adverse effects associated with this drug. Since it produces immune response, the results can be of allergic in nature, common cold, flu, back pain, redness, even allergic reaction at the site of the subcutaneous injection. However, few patients may show severe rashes, redness, severe itching, swelling of face. Those patients may require withdrawal of the drug. This is the trial, which busy slide I am not going to, I have already mentioned. The Fourier, evolocumab and ODC, this ODC outcome, long-term outcome, they are going to throw light in the near future about the major adverse cardiac events, and the advantages are what percentage advantages we are going to get. Therefore, in the recently concluded ESC conference, they gave a guideline how to give PCSK9 and what are the group of the patient. So the drug has arrived, and we have to now know when it has to be used. In a high-risk patient, in a patient of familial hypercholesterolemia and patients of intolerant to statin, these are the three basic indications where the PCSK9 should be given. We should start with the high-intensity statin therapy. If you get the desired level, then go ahead with the statin therapy. If no, then add ezetimibe. And even if adding ezetimibe, you are not getting the desired level of LDL-C cholesterol, use PCSK9 in the indications which I have mentioned. And these are the class of indication because it's still major trials are going on. 2BC in combination where it is high risk patient where the LDL-C is not achieved, and 2BC indication if patient is intolerant to the statin, and 2AC for the familial hyper. A word about the development of vaccine. PCSK9 immune response is important, and this has been presented by the Swedish group of scientists. They say that dendritic cells and the T helper T cells, they are responsible for the inflammatory nature of atheroma, and they can be targeted with the PCSK9. And by this, they have postulated that PCSK9 inhibition could ameliorate cardiovascular disease by immune risk mechanism, can reduce the burden of atheroma plaque, or even they can halt the progression of atherosclerosis. So, can it be used as a vaccine? It is a big question. So, I am concluding. Evolocumab and evolocumab, they are approved by FDA 2015, used both in Europe and America. The class of indication is limited, familiar, whether it's a hetero or homozygous, high-risk patients such as approved atherosclerotic cardiovascular disease, ACS, MI, and who requires LDS, further LDLC lowering, diabetic patient who are intolerant. Now the question arises here, can we use this drug as a monotherapy? Answer is still not known, but it is said that don't use it as a monotherapy. There are the challenges. It's a costly drug, approximately 1 to 1.5 lakhs rupees per month treatment. There is an allergic reaction at the site of injection. Approximately 6 ml of the injection has to be injected into subcutaneous gland. So it's a big amount and results into the allergic reaction that must be taken in. And long-term safety is still awaited, may get answer in 1 year time. Thank you very much.
Thanks, Dr. Sinha. It was a lovely display of PCSK9 inhibitors by Dr. Sinha. So I think just one comment, or we'll take one question. My comment is, the indication-wise very clear, despite a maximum use of statins, if LDL is still high, so those are the patients who fit into for indication of PCSK9 inhibitors. It's a subcutaneous injection, and the side effect profile is not much. So is that so? So that was the main message. Yeah. So I think we can take the questions later on at the end of the session also. We move along. Thanks, Dr. Sinha. The next speaker is Dr. Jasjeet Singh Wazir, and we have requested him to talk upon empagliflozins. There is a lot of discussion of these molecules giving a cardiovascular safety. Side by side, they are anti-diabetics, but also giving a lot of cardiovascular safety in patients of cardiovascular disease. So over to Dr. Wazir.
You have the slides? Okay, so I have deviated a little from the topic, and the topic I put as cardiovascular safety and benefit. So there are two parts to this. One, safety. Two, is it going beyond safety in providing us benefit, is what we're going to talk about with this particular drug, which has been now there for some time. I'm sure all of you have been exposed to the scientific literature. So I've divided my talk in the next 10 minutes in two parts. First part, we talk about the relationship of diabetes, the heart, the very basic principles of diabetes care and cardiovascular outcomes. See, it's extremely important. Why did I put these slides is all of us sitting here treat diabetes. But these basic principles are the guiding principles for the correct treatment of diabetes for prevention of heart disease. We all know two important facts here, that diabetes is increasing majorly in its prevalence and incidence, and not just increasing in numbers, but it is afflicting the productive population of our country and globally also. So every day you would find about, in between 9 of us consultants in our department, about 8 to 10 newly diagnosed young diabetics. Now imagine if somebody develops diabetes at 35 years of age, that gentleman or that lady is going to live with diabetes for that much longer. And the other important fact is the most common reason for morbidity and mortality in diabetics is cardiovascular disease. So one hand, we have increasing prevalence of diabetes. The other hand, the most common reason for morbidity and mortality in diabetes is cardiovascular disease. So we have a dual burden of non-communicable diseases which is increasing. So we need to alter this part of it, that is prevent diabetes, which is not a part of my topic of discussion. But if we can do anything other than what we're doing at this point of times, like ARBs, ACE inhibitors, aspirin, statins, and we just talked about newer LDL lowering agents. Can we do something more as far as glycemic control, control of diabetes, and reduction in CV death is what I'm going to talk about right now. The data from our country is very dismal. You see here the A, B, C. A is glycosylated hemoglobin, B is blood pressure control, C is cholesterol control. And in our population, this is a very recent trial in collaboration with the ICMR published. It shows that about 85%. So 85% means that almost all diabetics who come to you have either one of these or more components of major cardiovascular disease prediction which are uncontrolled. So overall, increasing the burden of cardiovascular risk, and which would finally culminate into cardiovascular disease, morbidity, mortality, more procedures, more PCIs, more bypass surgeries, and diabetics we know are more prone to develop multivessel disease. Well, that is not my forte to talk about cardiovascular disease and diabetes, the kind of arteries involved. But the other very important principle, which I would like to spend an extra minute on, is where did it all start? It all started in about the early 1990s by the UKPDS study, which is for the first time it was shown that controlling blood glucose levels. Now, important part is depicted here. These were newly diagnosed diabetics or those who had a shorter duration of diabetes without existing heart disease or aggregation of cardiovascular risk factors. So once you control their blood glucose levels very well, you find a reduction in macrovascular diseases and a significant reduction in microvascular disease. Okay, all good. So first time we know that glycemic control is equal to reduction in morbidity, mortality related to cardiovascular disease. But what happened once these patients came out of the trial and were followed up by their GPs? The interesting thing which came out of this is that the benefits of early intensive, two important words, early and intensive. So the take home message is the earlier you intervene, the more intense you are in your intervention, in especially those who have a shorter duration of diabetes, the benefits will stay on with them for a very long period of time, as long as 10 years or 20 years. And the reason is at the level of the cell, the mitochondria and the nucleus, uncontrolled hyperglycemia itself, and by virtue of increasing advanced glycation end products, leads to a cascade of metabolic changes which are permanent and which lead to persistent alteration of gene expression, which may be the predictor or the causative agent for occurrence of diabetes complication despite achieving a glycemic control. So what happened after the UKPDS, they thought, let's try it in a varied condition of diabetics who are 10 years, 20 years of diabetes, those who have heart disease, those who have multiple cardiovascular risk factors, mainly the ACCORD, the VADT, and the advanced trials. Unlike the UKPDS, these studies did not show that significant a benefit in cardiovascular morbidity, mortality reduction. In fact, one of the trials had to be prematurely stopped because of increased mortality in the intensive control group. So what is this happening? So take home message comparing the UKPDS from this is that the early on in the course of diabetes, you intervene with good glycemic control. I'm not going into the realm of antihypertensives, ACE inhibitors, aspirin or statins. I'm just glucocentric approach here. But we all know that a diabetic cannot live long or healthy without complications unless we do all of these things, which the Steno 2 trial has taught us, that it has to be a multi-pronged approach if we have to make our diabetics live long, healthy, without complications of diabetes. So post this came the rosiglitazone storm, where this anti-diabetic drug, rosiglitazone, was shown to increase the risk of myocardial infarction and death from cardiovascular disease, which warranted the FDA to issue the statement that any new drug for diabetes, any anti-diabetic drug, has to undergo rigorous cardiovascular protection, safety first. We are not talking about superiority of the drug in prevention or reduction of CV events. The drug has to be safe. And after this, these are the number of trials which are ongoing on anti-diabetic drugs. A lot of them have been published. A lot of them are due to come. And I would be talking about empagliflozin, the EMPA-REG outcome study, and as far as the drug going beyond glycemic control in its effect on the cardiovascular system. So just a basic prelude about how the glucose is metabolized or managed by the kidneys. It passes through the kidney. 90% of it is absorbed by the SGLT2 enzyme, which is in the proximal convoluted tubule, 10% in the distal part. So this group of drugs basically blocks the SGLT2 enzyme. So what happens by virtue of blocking this enzyme is that 90% of the filtered glucose will go off in the urine. Very simple mechanism of action of this drug, that the patient takes out more and more glucose in the urine. So coming to EMPA, just not talking about the pharmacology, very important thing here is a patient who is taking the average dose, which is 10 or 25 milligrams of EMPA, would pass about 90 grams of glucose in the urine every day. So glucose loss is equal to calorie loss. Calorie loss is equal to blood glucose control, is equal to weight loss. So if you're losing calories, obviously you're losing weight also. And that is the extra benefit of this drug in not just providing glycemic control, but also helping in weight loss. So the EMPA-REG study, it was a truly global trial, covered 590 cities from 42 countries. We had a good representation of 200 patients from our country, a randomized double-blind placebo-controlled trial to look at CV outcomes of empagliflozin in high risk, important to know, high risk patients with established cardiovascular disease. So over 80% of these patients who were enrolled in this study were high risk patients with established cardiovascular disease. So I've already talked about, it's a highly selective SGLT2 inhibitor. Mechanism of actions we've already talked about. So the three clinical, whenever a patient comes to me in my clinic or to your clinic, the four things which I would feel are mandatory to be told to the patient, that this drug is going to help in 1, most important, sugar control, 2, help in weight loss, 3, help in blood pressure reduction, and the fourth point, the cardiovascular outcomes with this drug, I'm going to be discussing in the next last few slides. So the study enrolled about 7,000 patients, 97% completed the trial, and this was the trial design. Now, the primary outcome was the 3-point MACE, which is the kind of standard which the FDA has proposed. As you can see, that these patients were already on kind of maximal cardiovascular protective drugs, include ACE, ARBs, statins, and aspirin. So the primary cardiovascular outcomes, the 3-point MACE was reduced by about 14% with both doses of empagliflozin. Cardiovascular death reduction by 38%. So the main driver for the cardiovascular benefits of empagliflozin was reduction in cardiovascular deaths. Important point here is that the protective action of the drug started as early as 6 weeks of starting the drug. Irrespective of their age, their gender, their race, their levels of A1C, the benefits on cardiovascular deaths were maintained throughout these subgroups. Hospitalization for a heart failure, reduction in 35%. Again, it started as early as 6 weeks. All-cause mortality, 32% reduction. So keeping these cardiovascular outcomes in mind, both the ADA and the ACE bodies endorse empagliflozin to be used in high-risk patients or patients with established cardiovascular disease for reduction in cardiovascular morbidity, mortality, all-cause mortality, hospitalization for heart failure. Well, the last two slides, the probable mechanisms of actions of these drugs, because of paucity of time, cannot go in the details of this. Maybe we can have a Q&A on this. And one of the important mechanisms of its cardiac protection may be subclinical levels of increased ketones in the blood. So this we'll skip. So the summary of the EMPA-REG outcome trial was 3-point reduction by 14%, HbA1c reduction, less hypoglycemia, weight loss, blood pressure reduction, increased in the large, dense, buoyant LDL molecules which are less atherogenic, and increase in HDL, increase in genital infections, but not a very important thing. If you educate the patients well, this is not a deterrent of use of the drug. CV death, which was the main driver of cardiovascular benefits, reduction by 38%, all-cause mortality by 32%, reduced hospitalization by 35%. Now, these are large numbers of cardiovascular benefits of a drug in a patient with high risk for cardiovascular morbidity and mortality. So the last slide, from CV safety, the fish is jumping into CV protection and giving us a way of reducing the mortality and the morbidity in our high risk diabetic population. I thank you very much for your kind listening.
Again, something very big information. So we are not the diabetologist, Dr. Wazir, but the message is very clear that this drug provides a very good cardiovascular protection, or it improves the survival from cardiovascular point of view. So my just one question before we really proceed on to the next talk. Now with this kind of data, with this kind of very strong data, still, I think as a diabetologist, you prefer metformin as the first drug, and this comes second, or should we really change the scenario now with this kind of strong data?
So metformin still, as per the guidelines, because we practice evidence-based medicine, metformin still would stay as the first line drug. Now, the ACE guidelines have put the SGLT2 inhibitors and the GLP-1s together as the next possible second line based on the cardiovascular benefits. But again, we have to individualize a patient. So I'll give you an example. Uncontrolled diabetic with multiple cardiovascular risk factors or established heart disease who is obese would be the ideal candidate, because all the four benefits would help this patient live long and healthy without complications. So definitely your question is very valid in upgrading the use of SGLT2 inhibitors in our diabetic patients. But the best thing would be to refer the patients to us.
That we always do. So thank you, thanks Dr. Wazir. I think he deserves a big applaud. So next on the agenda is two very important talks, and that deals with transplants. So I think suddenly we feel that there is a lot of thrust in this, and the times are changing. While we were not thinking of transplants in our society, but now, or it was only restricted to southern India, but now with the turn of events happening in northern India also, so there is more and more surgeries of transplant being happening. So that's a very good news for our part of the society. So I think we deal with that. So next, I can call upon Dr. Vivek Singh. Is he around? Yeah, Dr. Vivek is here. So this is a very important and very exciting topic. The Eisenmenger syndrome, we actually in our practice, we deal with these cases day in and day out. And up till now, we were thinking that we don't have anything to offer to these patients. But I had a discussion with Dr. Vivek in one of my patients, so even I got enlightened. So I thought, let's put it here. So Eisenmenger syndrome, does lung transplant generate a hope? So I leave it to Dr. Vivek to put light upon this.
Good morning, everybody. Thank you for inviting me here. So lung transplantation So if you look at just going into the history of lung transplantation, between 1963 and 1983, there were around 44 unsuccessful attempts to do lung transplantation. In 1980-81, in Stanford, the first successful heart-lung transplant was done, and then in 1983, Dr. Joel Cooper did the first successful single lung transplant at Toronto General, and in 86, they did the first successful double lung transplant. If you look at the numbers of lung transplant across the globe, the green one signifies the single lung transplants and the purple one is the double. We see over the years, the double lung transplant is gaining more and more, and the single lung transplants have remained more or less constant over the years. Going by the diseases for which patients are being offered lung transplant, I think COPD and ILD remain the leading indications. Initially, it was COPD for which transplants were being done, but gradually interstitial lung disease are picking up. Coming to the PAH, which includes transplants for Eisenmengers as well, this has remained more or less, the blue one represents the number of transplants happening for PAH, including Eisenmengers. So they have remained more or less constant. The survival for lung transplant, according to the indication for which the transplants are being done, the best survival is seen in cystic fibrosis patients, and one of the reasons for this being that these patients are transplanted at a younger age compared to other indications like ILD or COPD. But the mean survival post-lung transplant is close to around 5.5 years. It varies according to the age of the recipient between 6.7 to 4.5 years. So more is the age of the recipient, the survival does get a little compromised, but on an average, the survival is close to around 5.5 years across categories. The leading cause of death post-lung transplant, if we see that in the initial phase, early post-transplant, it is the infections which predominate, and later on, as years pass by out of transplant, the bronchiolitis obliterans syndrome, or now what we call as the chronic lung allograft dysfunction, or the CLAD, is the major cause for mortality. Now coming to Eisenmenger syndrome and lung transplant, so heart and lung or lung transplantation as alone with intracardiac repair of the defect are the treatment options for Eisenmenger syndrome. The International Society of Heart and Lung Transplant has put as the indication of referral for such patients to a transplant unit as somebody having NYHA class 3 or class 4 breathlessness in spite of maximal medical therapy, or in whom the disease is rapidly progressing. For the indication of transplant, people who continue to have persistent breathlessness class 3 or class 4, who have a low walking distance of 350 meters or more, or if you find that the 6-minute walk distance is declining over the period, patients who are failing therapy with IV epoprostenol, who have a cardiac index of less than 2 liters per minute per meter square, or who have a right atrial pressure exceeding 15 millimeters of mercury, should be considered for transplant. Now coming on to heart-lung or lung transplantation for Eisenmenger syndrome, this meta-analysis was done for the UNOS data for 605 patients with Eisenmenger syndrome who received lung transplantation. And what they said was that this analysis suggested that for Eisenmenger syndrome recipient is not a homogeneous group. And the patients with VSD and multiple cardiac abnormalities have the best prognosis. And in these patients, heart-lung transplant appear to offer a survival benefit when compared to lung transplant alone. In another meta-analysis for heart-lung transplantation for Eisenmenger syndrome, published in the Annals of Thoracic Surgery in 2001, they said that the heart-lung transplantation was a successful procedure for Eisenmengers, and despite a greater frequency of risk factors and more difficult post-operative course, early and late outcome of a heart-lung transplant is comparable to those in patients who do not have Eisenmengers. So what should we say? Is it heart-lung or a lung transplant alone? So we do agree that the registry data does suggest that the heart-lung transplant is a preferred procedure, particularly for VSD patients. But there are certain disadvantages when we are listing patients for a heart-lung transplant. One, they need to be on the bypass for a longer period of time. In fact, lung transplant patients are being operated without a pump on ECMO itself, and the ECMO is being weaned off by the time the surgery is over. Second is we are exposing the graft to both graft coronary vasculopathy and chronic lung allograft dysfunction, which may hamper the survival. And of course, the waiting list time increases when the patient are being listed for heart-lung transplant. So to say we cannot definitely say that whether it should be a heart lung or a double lung transplant only for these patients. The choice of the procedure should be individualized. Definitely, heart lung transplant is preferred procedure for patients with complex congenital heart diseases with Eisenmangers, or patients who have unsuccessfully repaired or uncorrectable lesions, or those who have severely depressed LV function. Coming on to lung transplant, what are the contraindications to do a lung transplant? So any recent history of malignancy, we require a 3-year malignancy-free period before these patients can be listed for a transplant. Untreatable dysfunction of other major organ system, uncorrectable atherosclerotic disease, not amenable to vascularization. So the dictum goes, if the patient is amenable for revascularization, PTCA should be attempted and the patient should be listed after 3 months. And if the patient is a candidate for a bypass surgery, then both the surgeries are done in the same sitting. Acute medical instability, uncorrectable bleeding diathesis, substance abuse, chronic infection, active Mycobacterium tuberculosis infection, significant chest wall deformity, which may make the surgery more difficult, class 3 or class 2 obesity, the ideal BMI is close to around 24, and if we have questions about the adherence or to medical treatment. I just want to come to the relative contraindications. The one in red were absolute contraindications till a few years ago and now have become relative contraindications. So age more than 65. Around 5 years back, this was an absolute contraindication. We were not considering patients for lung transplantation who were more than 65, but now it's a relative. Extensive prior chest surgery with lung resection, mechanical ventilation and ECMO. Now programs have started transplanting people off ECMO. Hepatitis B and C, and so they have been relative contraindications for lung transplantation. What are the criteria for good donors? So a P/F ratio should be more than 300 after recruitment and diuresis. A chest X-ray should be clear. Bronchoscopy should not reveal any evidence of aspiration or purulent secretions. And now, because of the scarcity of organ, we've extended the criteria for our donors as anybody younger than 55 years of age with an accumulated smoking history of less than 20 pack years is still accepted as a donor, shouldn't have any history of pulmonary diseases, chest trauma, and the gram stain should be negative. We don't wait for the cultures. But the matter is that there is a shortage of organ throughout the world. So every organ matters, and there are certain ways which have been devised to use the maximal number of organs which are being donated to us. The picture which shows is a technique which was developed at Toronto. It's called as the ex vivo lung perfusion. So lungs which are borderline, which are marginal on our initial assessment, are brought to the hospital and they are healed on a system which is called as the ex vivo. So this is the system. So the lung is connected to a conventional ventilator and it is put on a circuit which is a deoxygenator. So we keep on, and it is perfused with a perfusate solution. And what we do is there's a constant addition of carbon dioxide to the circuit. And with the ventilator, the lung is ventilated. We keep on repeating our ABGs through the outflow limb and see how the lung is functioning. With this procedure, it has been shown that lungs which are congested, overloaded, we can dry them out, and these lungs become transplantable after 4 hours. So maximal time what is spent on an EVLP is around 4 hours. We do an hourly assessment for these lungs. And the Toronto experience shows that we are able to use 55% more organs which are donated to us. There's no survival difference between a lung going on an EVLP and the lungs which are transplanted directly. So just to conclude, we can say that transplantation is definitely an option for selected subset of patients with end-stage heart failure and end-stage lung diseases. And heart-lung transplantation should be limited to patients in whom it offers the only surgical option for their end-stage heart and lung failure. Thank you. Thank you very much for a patient hearing.
Thanks, Dr. Vivek. I think it was again a very important thing for all of us, because what we see, that's what we believe. So I think many of us maybe still not aware that this is therapy which is existent, which can give some ray of hope to these end stage patients of Eisenmenger, where we usually think that nothing can happen. I think there are many families who can actually think of this and come out with this option if it is discussed with them. The problem is we don't give them a option that this is something which is existent. So I think then the other question starts, that whether the donor is available, it's in the waiting list properly, the indications, contraindications. But then if we are not aware that we have to offer them this modality, then we are not taking that step.
I agree. And I think about lung transplantation, the important thing what they say is there's a very narrow transplantable window. So they say that this transplantable window is close to around 2 years. So you want to catch the patients in the pre-transplant window. As they say, the indication for referrals are very clearly defined by ISHLT. So the referral should be made at that point where we see that patient may progress or require a transplant. That's our presumption. And once they fall into the absolute criteria for transplant, then they should be actively listed and transplant should be considered.
So basic message which we want to deliver here is that at Medanta we are all geared up for this. Cardiac transplants are already being done now frequently. I think next on the agenda is Dr. Bhan, who is a transplant surgeon at Medanta. He'll put light upon that. But also for the lung transplant, we are absolutely geared up at Medanta. So any patients, in practice which you see out there with Eisenmengers or heart lung together. So I think if those can be worked up, it would be really great. Thank you. Thanks, Dr. Vivek.
Thank you very much.
So we continue the momentum of transplant, and we have a very senior guy, very learned guy as a cardiac surgeon. And as I just mentioned, then Dr. Bhan has done I think 5 or 6 transplants at Medanta already. So at our center it is now happening. So as I mentioned prior also, there was a feeling that it's all restricted to southern India prior, but now this is already happening, and nobody would be better than Dr. Bhan to speak upon this topic of cardiac transplantation in India and what are the real problems which we face in northern India to give the momentum to this program. Dr. Bhan, please.
Mic working? I'm not too sure about that. Okay. So I'm basically going to highlight some of the issues in my presentation. What's the burden of heart failure in India? The natural history of these patients if left untreated, the treatment options, the need for heart transplantation, the results and the hurdles. Well, I think I'll take a little extra time because a lot of issues which might be of interest to the audience here. The heart failure is a big problem now. 5 million people in America having heart failure and almost 550,000 getting added to this list every year. And this problem is catching up in this country with the population growing in the age. We have a huge cardiovascular disease load in this country, and today 29% of the patients die of cardiovascular events, which is the second common cause of death in this country. And if you look at the data from All India Institute, I was just talking to one of the senior consultants there, 20% of the patients in their outpatients are heart failure patients. There are no population-based studies, but most of the studies are hospital-based, and most of the hospitals have a similar experience to share. And the burden of cardiovascular diseases and heart failure in Southeast Asia is growing very rapidly, and India is far ahead in these numbers. And if you look at the natural history of these patients, what happens to them? At 1 year, only 25% of these patients who are in stage D of their heart failure are surviving. And that's worse than any of the worst non-cardiac diseases which we can think of. Well, there are alternative options which you can use to buy time, to salvage these patients, like doing off-pump coronary artery bypass surgery in these patients who have a significant viability, the transmyocardial revascularization, the ventricular restoration procedures, the Bethesda procedure, which is of course a historical procedure now not being practiced very often, the atrial fibrillation surgery to improve their cardiac outputs, the biventricular pacing, mitral valve repair in patients who have end-stage heart disease, significant mitral regurgitation, and who are symptomatic because of it, and also the stem cell therapy. Well, these are therapies which can be alternative options just to delay the heart transplantation or the assist devices. Well, in US, the traditional approach for all patients with heart failure would be cardiac transplantation as the first option. There's a lot of work happening on xenograft because pigs are genetically closer to us. So some work is happening on the pig heart transplantation, but it's not a clinical reality as of today. And of course, total artificial hearts and ventricular assist devices, because availability of organs is a big issue. Well, if we look at the historical aspects briefly to say, it was Alexis Carrel who did a lot of experimental transplantation work way back in 1912 and who was working at the University of Chicago and got a Nobel Prize for the same. The spade work for the entire transplantation program happened at Stanford by Lower and Shumway. Norman Shumway was the person who did the entire clinical research, the experimental work, and developed the technique for the biatrial the transplant techniques. But fortunately or unfortunately, it so happened that Christian Bernard, who was visiting that center just to see what's happening, he stole the show and went back to South Africa and did the first cardiac transplant and became a hero overnight. And it was, of course, Norman Shumway who did later the first heart transplantation in US, but historically it was the first transplant done by Dr. Christian Bernard in South Africa. And of course, Kantovis, who contributed to a great extent by developing the intra-aortic balloon pump, which was a support therapy in patients with heart failure. Well, there was a lot of enthusiasm to start with in 1967 to 71, but the results were not good. And it was an issue in 1971 from the Life magazine, which showed a new report of an era of medical failures. That means heart failure had been recorded as a failure therapy. It was subsequently realized that there had to be something which had to be done. And main problems are the infection and rejection. So developing of the endomyocardial biopsy techniques to pick up the early rejection and treat it accordingly, understanding the rejection, developing the new immunosuppressants, and it was in the early 1980s when cyclosporin came in and revolutionized the entire solid organ transplantation outcomes, not just the heart, the kidney, the liver, and other solid organs. Treating infection and sensing infections are developing and treating them at the right time. And of course, lots of new immunosuppressants are available today, which have revolutionized the outcome and the long-term results of these solid organ transplants. Unfortunately, the numbers are not growing because of the non-availability, or I would say the paucity of the organs. If you look at this data from ISHLT, the numbers have virtually static, around 4,000 to 4,500 heart transplants world over, majority of them being done in US and followed by Europe. But if you look at the outcomes, the 10-year survival is now close to 60%. And whereas if left untreated, there are only 25% of these patients surviving at the end of 1 year. So results are dramatically improved with better immunosuppressants, control of infection, early recognition of rejection, and treating it accordingly. You'll be surprised to know Tony Hosman was one of the longest survivor post-transplant heart transplant who lived for 29 years. And another noted heart transplant recipient, Kelly Perkins, who is a mountaineer and brings about awareness about heart transplantation by his mountaineering events. Well, the story in India started in 1994 when the THOA Act came in, and the purpose of this act was regulation of removal, storage, and transplantation of human organs for therapeutic purposes and for the prevention of commercial dealing of the human organs, which was supposed to be a big problem. And the recognition of the brain death, which was an important thing to happen, the legislation came through and transplant became possible. And subsequently, some amendments in the THOA Act in 2011 to facilitate the process of transplantation. And the entire story of cardiac transplant started in 1994 at the All India Institute of Medical Sciences, where Professor Venugopal did the first transplant, and I was one of the lucky ones to be part of this team. We did the first transplant on 3rd of August 1994. And let me tell you, historically, just 1 month prior to that, he had been to the Temple University to visit Dr. Jivanandam, who is the person who helped us in developing this program at All India Institute, and spent a week or 10 days there, got to see about 2 or 3 transplants, came back, and within 15 days, we did the first transplant at All India Institute. The number of transplants stands to 320. Now, I think the number is 450, close to 450. Majority of them being done in South India. It's very interesting because their transplant rules and regulations are much more flexible than they are in India, than they are in North India. And I think the awareness of the people in South India is much, much advanced than what we have in North India, and they are much open to organ donation than what's happening in the North India. And there are multiple reasons for that, which I'll talk about in my subsequent presentation. The Delhi has had around 60 transplants, most of them at All India Institute, 47. This is the figure which they gave to me last year. And other centers doing some transplants. Of course, the numbers have to catch up with the South, then only it's possible to increase the numbers of cardiac transplantation. As we know, the indications are very standard: patients with refractory heart failure, with minimal comorbidities, adequate psychosocial support, medical compliance, which is very important because we had our first transplant patient who would not take medication, who would just stop medication, and we had to readmit her twice for rejection, and then we had to organize her funding for medication through some NGO. So we have to work on these before we accept them for heart transplant, because they have to be very, very compliant people before we accept them and put them through a transplant process. No substance abuse, and generally more than 65 years of age, we would not accept for any heart transplantation procedure. I'm not going to talk about the contraindications, but I think important issues which we need to address to, which are pertinent to us in our scenario. One is the organ availability, then setting up and conducting, take care of these patients post-operatively, immunosuppressants, their availability and the cost issues, infection, rejection, funding, because some of these patients need to be readmitted, as you will see, for a variety of complications, and readmission is a big issue. Role of the coordinating agencies, the level of education and fate of the waiting list, assist devices programs, and a teamwork. So shortage of organs is a big issue. Though you'll be surprised to know there are about 60,000 accidents happening in this country every year, and about 5,000 road traffic accident deaths in Delhi itself, but just a handful of cadavers. The most likely reason for that is that these brain dead patients are not admitted. And if at all there are any road traffic accident patients admitted, they get into neurology or neurosurgery. And unfortunately, the initiative taken by the respective treating teams is not to the level that we expected. And lack of awareness among the doctors about the benefits of the organ transplantation is a major problem. At my own level, I did some work, and I'll tell you, you'll be surprised to know there are about 50 brain deaths in All India Institute every year, 40 at Safdarjung Hospital, and RML Hospital around 30. I was talking to our neurology ICU coordinator, and she tells me we have almost 4 brain deaths every month, and we never get a call from our own neuro ICU. So there's a problem somewhere. If you permit me some more time.
Take your time.
There's a problem somewhere that lack of awareness and lack of coordination between the location where they are placed in the ICU and our own surgical team, because we are not permitted to go and see these brain dead patients unless we get a call from the treating unit that there's a brain dead patient. And then there are other issues. Very few centers are authorized to certify brain death. Maintaining these brain dead patients in the ICU is a big issue. The cost incurred on that, utilization of facilities, TPS don't give any kind of financial support for these patients. In West, there is almost a 20% acceptance rate for those who agree to donate organs, but this number is much smaller in our country. Lack of understanding about brain dead status. Beating heart, generally people will say if the heart is beating, then the person is not dead, irrespective of the fact that you educate them that he is in a vegetative form. And images of harassment, and this is a reality. Form filling, documentation, there's so much of hassle involved in that. and not getting the body at the right time. I'm telling you, so many times we have got calls saying that we are willing to donate the organs, but we want the body back by 3 o'clock. And logistically, it's not possible. Suppose an outstation call, going and getting the organs and releasing the body in that stipulated time. So family is very keen. We are willing to donate, but we want the body back at 3 o'clock or 4 o'clock because there are some rituals to be done. And quite often we have to give up because we could not adhere to that time. And of course, the myth, soul exists in the heart. It's very difficult to wash off this myth from the minds of the people. And unfortunately, heart is supposed to be the seat of the soul, so it's very difficult to convince them. Donor pledge cards. We don't have anything of this kind existing, at least for the heart. There's something happening in the eye and other organs, but nothing for the heart. And in the Western countries, there's something called a presumed consent, that you assume if somebody is brain dead, you can utilize his organs. Again, that's not relevant to our own country. The legal system does not permit, so we don't have any presumed consent happening in this country. So we need to build up the desire. And the most important thing which contributes to the willingness of the families is the education level. And that's a very important thing. And you see South India, the education levels are certainly higher than the North India, and therefore their organ donation programs are working in a much more streamlined manner than our own program. And other problems, of course, religious and cultural diversity, a poor socio-economic backup, and lack of infrastructural support for implementing the cadaver transplant programs. Well, in this direction, I can tell you government has played a very important role in providing us the green corridor whenever the heart has to be transferred from the airport or some other location. In our own experience, the first patient, we got the heart from Indore, and we were almost touching the stipulated 4-hour ischemic time. But believe me, in 14 minutes, I think from the airport to Medanta, we could shift the organ. And the important thing which I want to share with you is this very interesting device which has been developed by the Transmedicos, where you can keep the heart beating by perfusing it all the time before you actually implant. So you are cutting down the ischemic times and decreasing the injury to the myocardium before you implant the heart. This is a device which is not available in India right now, but I'm sure very soon this device should be available to us, and it will make our outcomes of transplant much better. And I think it's going to the device is going to definitely influence the outcomes of transplant program in any center. And that's a heart. And just before implantation, you just disconnect the perfusion, and you will see the heart stopping slowly, and then you get ready with the implantation technique. And this is where we started. We did our first transplant April of 2016, and subsequently we have done 5 transplants at Medanta in Gurgaon, and 1 transplant I did at Medanta Indore, because the MP laws generally do not permit to get the organs out of that place. So the Commissioner of Indore is very keen that whatever organs are available, they should be utilized in Indore itself. Well, there are some recipient problems, and which are very genuine problems, I can tell you. You call up the recipient who is already worked up thoroughly for the transplant and tell him that organ is available. He says, no, it's a festival time now, we don't want to get a transplant done, or some family function happening. Or if the recipient is too far away, not possible for him to reach the center to get the transplant done. And sometimes when we call up the recipient is already expired. And sometimes they would say, no, we're feeling better with medication now, I don't think I'll need a transplant. So these are real problems which we face in our day-to-day practice whenever we have an organ available and recipient is not willing. And when the recipient was there, willing for transplant, the organ was not available. These are the pictures of the 3 transplant patients done at our center and doing extremely well. We done actually 5 at Medanta now, and as I said, 1 at Indore. So other issue is the transplant coordinators. There are no well-trained transplant coordinators. They just are self-learned people, and we're utilizing their facilities. But there are 2 or 3 important issues, that there are some coordinating agencies which are now trying to educate these coordinators, and Mohan Foundation is playing a very important role in this direction to educate these coordinators so that their skills can be utilized in the right way to develop the transplant program. In the initial stages itself, ORBO was set up at All India Institute, which is an organ retrieval and banking organization. The purpose of this ORBO was to ensure and facilitate a fair distribution of organs. Government has taken a major initiative by setting up the NOTO under the Director General Health Services, and again this is playing the same role as UNOS in America, and their job is again for a fair distribution of the organs. And of course there are certain issues. Right now it's operative in North India, though it's supposed to be an all India organization, but now at the state level also similar organizations are being created so that the organ transplantation process can be facilitated. And at some point of time, I think notification of brain death is going to be mandatory so that more organs are available. So what do we need to do? We need to coordinate the activities between the coordinating agencies and the transplant teams. The availability of the recipient list should be always available. Like whenever we work up a patient for transplant, it has to be uploaded to the NOTO website so that they are in knowledge of the patients who need a transplant and who are status 1. That means who are the ones who need the transplant on priority. And it has to all work like a well-oiled machine. Well, there are problems, infection being one of the major problems, and with any solid organ transplantation, the infection is a possibility. I don't want to go into the details. The actual freedom from infection being less than 10% at the end of 10 years. So every patient, transplant patient, would have got exposed to some kind of infection at some stage in the post-op period. But that's not synonymous with death. They can be treated if the infection is picked up at the right time. And actual freedom from infection-related deaths is around 30-40% in patients at 10 years. Immunosuppressants are not a problem because there are robust kidney transplant and liver transplant programs happening, and immunosuppressants are available. All kinds of immunosuppressants are available. So that has really revolutionized the outcomes of these heart transplants. The outcomes of heart transplantation, the typical cause of death in the first year is either due to rejection or infection, and after first year the primary cause of death is usually a vasculopathy in the allograft. Another problem that can happen in these patients is developing a variety of malignancies, and non-Hodgkin lymphoma is one major problem. The incidence is much higher in heart-lung transplantation because you require a much higher dose of immunosuppressants compared to heart and other organs. And the last important issue is the financial implications. The cost of surgery in the initial periods are 10 to 15 lakhs. The immunosuppressants would cost 10 to 15,000 per month. And if there is need for any extra immunosuppressants, higher grade immunosuppressants, that would definitely be much more expensive. And it may not be possible for all the families to support this kind of a treatment in terms of finances. But getting a 60% survival at 10 years is worth it, and all these things have to be discussed with the family before going for the transplant process. The GDP is an issue because we are at a much lower level than US and other developed countries like Japan. Therefore, that becomes an issue, and no kind of insurance will support this kind of a program, be it transplant or be it the ventricular assist devices. So there are some suggestions the government should aid these programs. Well, for government hospital, they do sometimes. All Indian Institute is running its heart transplant program at a very less price, about a lakh of rupees for every patient. And all high volume centers should absorb the cost. Let me tell you that we're very fortunate. The Dr. Trehan has been very kind in cutting off the extra money, and whatever the patient could afford, we have been able to do these transplants with that minimal amount of money. And agencies to mobilize funds for these patients. Now, how to get there? There's a potentially huge pool of brain death patients in the country. The education of public on the concept of brain death is very important. Allocation of resources from government and private agencies for these programs, and having a state-based network is something which needs to be done. And certainly initiative has been taken in Haryana to have a state-based organ allocation system at the same pattern as the NOTO at the All India level. And of course, advertise the benefits of donation, which is happening now much more frequently than what we used to see earlier, and facilitate the organ retrieval, because presently the Act requires 4 doctors to diagnose brain death at 2 occasions at an interval of 6 hours. Perhaps we could follow the Western model where 2 doctors have to do it at an interval of 2 hours. So that would make more organs available, because if you delay the organ retrieval, sometimes these donors deteriorate during that period of time and they become unusable organs. So Indian heart transplantation program would go through a gestation period before it really picks up. I think it's come a long way, but still not reached where the Western people are. And just to say, if something comes to life in others because of you, then you have made an approach to immortality. Thank you very much for this patient hearing. And I tried only to project what we are facing in our day-to-day practice vis-a-vis this modality of treatment. And I'm sure over a period of time, we will overcome these issues and we will, as patients and their relatives get more and more aware of these problems.
Well, thank you, Dr. Ban. I think it was a wonderful talk on cardiac transplant, the problems which we face and the success rates, everything he covered literally well. So I'll just add upon two things. Firstly, it's a mindset. Mindset starts with the physician, clinician, and cardiologist, whomsoever is into that zone where they are facing that there is availability of organ donation. That's one on one side, and second, the end stage cardiac patients. So are we really thinking of something for them in those subsets who are really who can really afford? So maybe that area is not well covered still. So I think if we have a patient of end stage cardiac disease who's affording in some manner or the other, firstly we have to discuss with them that this is an option available to them, and secondly, then if there is an agreement, there is acceptance of the family or the patient to go ahead, then they need to be enrolled. They need to be enrolled into the NOTO. That's one area. And second, they need some testings which are not very complex, which require a day or two, where we require to have a cardiac cath to have the pulmonary vascular resistance and the coronary angiogram and other things and some blood tests. So 1 or 2 days in the hospital, and then we can really enroll these patients into the NOTO, and depending on the waiting list movement, they can be really a candidates for cardiac transplant. So,
Just to add a line, when I was sitting here in the audience, Dr. Kasiwal walked up to me and said, there are 2 patients in heart command who need to be seen for potential transplantation. And Rajneesh also has a patient. So, there is a change of mindset already happening, and I can see it actually happening. Thank you very much.
yeah. Any of the questions from the audience on the transplant? Mike, please.
Sir, it was a wonderful talk, very educative for us at the periphery, and in fact, the doctors has to be sensitized first. Then only the message can go around. And I want to tell that I have 2 NOTO trained technicians in my hospital. I have always been wondering what can they do there. In case you want to have any activity just to sensitize people, we are open. And of course, Dr. Kasliwal knows the press is always there. Jalandhar is a center for the vernacular press.
What's the kind of training they had?
They had 5 days training in Delhi
No, as transplant coordinators?
as transplant coordinators. I don't know. There was 5-day training they came last month only.
If they are interested, they could just come over and discuss with us and see, because we are already looking for one trained person, because right now who is working for us is not a trained
I don't want to
transplant
lose him, lose them. That's
I
a
thought,
couple.
honestly, I thought you were willing to hand over one to us, so I don't know.
My problem is that it comes as a package because they are a couple, husband and wife.
So are they helping you with the surgery also?
No, sir, they are not at all. They are just, one is BSc nursing, another is MSc nursing.
Okay.
They are helping me in the hospital quite tremendously. But I would like, if you want, that we can have some program there to sensitize from Medanta.
Sure, I think we'll work on that. I'll speak to Dr. Kasiwal, and whichever we can utilize their skills and knowledge, that will be nice. Thank you very much.
Well, thank you, Dr. Ban. Let's give him an applaud. We move on to the next. It's a very important topic once again, and we have a really good speaker on this, Dr. Kasliwal. His name requires no mention, and I think there's a lot of things to be learned from Dr. Kasliwal. I have personally done that during my last 20 years, and I think the number of candidates or number of students he has mentored is really huge. So, Dr. Kasliwal, over to you. He's speaking upon pre-disease. So, before it really sets in, how to pick up the disease and what are the points where we can really try to avoid having a disease, cardiac disease? Dr. Kasliwal.
Thank you. Ladies and gentlemen and august audience, it's a real honor to be here. Dr. Kapoor and I have been together for the last 20 years of our lives. We have traveled together, and this is his vision that in a conference predominantly meant for interventional cardiologists, he's actually thought that, pre-disease is a concept. So let me take it from there. The two previous speakers, you could see the pain in their voice because they felt that in their specialties, there was just too much burden of cardiovascular disease, including ischemic heart disease. If you saw the Times of India the other day, they said that of the 50 biggest causes of death all over the world, the biggest blob was actually the cardiovascular disease, which didn't include cardiomyopathies and rheumatic heart disease. It was only ischemic heart disease. So India definitely is headed for trouble. And of course, we may do lots of things. I mean, we can do procedures, we can do, but there is, if you can preempt it, then that's the whole thing. So from Harvard School of Public Health, an Indian student said that India would incur a cost of almost $4.5 trillion due to NCDs and mental health conditions. And that's not a figure to trifle with. These are all data. And they have come from the UN, which headed a panel saying, it's called 20 into 25, that by the year 2025, you should be able to decrease the burden of cardiovascular disease by 25%. So 2025 is something which we all have to look at. CV risk assessment, let me start then, is the cornerstone of preventive cardiology. So we have progressed so efficiently in so many interventional procedures, but we still do not have a risk profile which can identify Indians at risk. The Europeans, the Caucasians, the blacks do not follow us. We are different, they are different. And we published many years ago a data saying that low Framingham score, despite high prevalence of metabolic syndrome, saying that there is, and we have huge organizations, but we don't have a risk stratification algorithm in India as well. So how do you assess CV risk in Indians today? Actually, no score is truly available. We did one, and this data was published in the Indian Heart Journal a couple of years ago. What is the comparative accuracy of different risk scores in assessing cardiovascular risk in Indians? First time ever published. Now, just imagine these people, we took a small, and we are now building it up, but it's a small cohort of patients. Imagine these people were sitting in your office a day before they got the MI. And you would say, yeah, you have a chance according to the criteria, and I'll tell you that. So these were 149 patients, mean age 59, hypertension, as you can see, diabetes, all had STEMI, and we applied 4 risks to them. The most commonly used risk scores in the country: FRS, new SSC, AHA, pooled cohort equation, the JBS3, and the WHO risk prediction charts. Just see how they go. These are people sitting in your office and say, sir, do I have a chance of getting a heart attack in the near future? The Framingham risk score would have given them a chance of 20% risk of 38%. ACCHA pooled cohort, America speaks so much about it, about 30%. The JBS3, and I'll come to that, this is the closest score because it has a lot of Indians. This is the Joint British Society score, started from England, and this gave a score of 55.9. The WHO was dismal, 13.4. So if your cornerstone of pre-disease is not available, then certainly not much can be done. The JBS score, please go on this score on the internet today. Put in your name, age, data, LDL cholesterol. Not only will it give you, an Indian is there, in the ethnic group is there, very clearly, it will give your heart age. And it will also give you the risk of heart attack or stroke in the next 10 years. So we are moving forward from the cornerstone, which we lacked. We are moving forward, but this is not data from anywhere in the world. We are now talking of our own data. Then we moved forward. We said, look, is there just a lipid profile can't tell you whether this person is going to have a heart attack or what's going to happen. So we said, all right, we'll look at subclinical atherosclerosis. And this was a relationship between different cardiovascular risk factors. risk scores and population, and measures of subclinical atherosclerosis. The whole meat, as Dr. Bhan was saying, that it is intuitively that there are 4 brain deaths taking every month, but nobody knows. Intuitively, we should be able to say, yes, here is a patient who's at risk. Can I do something for him now rather than wait for him in the emergency room 3 years later? So we started a muhim almost 20 years ago when the first paper was published. The Indian Heart Journal didn't actually even accept it, so we sent it abroad. Abnormal vascular health is the one that we have to look at. Flow-mediated vasodilatation. If that is abnormal, if our colleagues who look at hypertension patients and diabetes patients, if they were aware of the fact that this is where to start, the things would be very different. From abnormal vascular health, you go to atherosclerosis, you get 10 years. And then you will, of course, we see routinely acute myocardial infarction, strokes, and peripheral vascular disease. But then you can do only so much and no more. So flow-mediated vasodilatation, now echocardiography is not required. We developed an instrument which is going for FDA approval by a company that you can do it by an algorithm, by just a computer-based technique. So this is baseline, this is post-tourniquet release. The basic thing is, are your vessels stiffened or non-stiffened? Will they expand in diameter after the tourniquet has been released or not? Simple. So the MISA study, and all of us who are interested in cardiology do read the MISA study, multi-ethnic study of atherosclerosis, and they say that if your brachial artery flow-mediated vasodilatation is abnormal, and this is the data, and so those who had FMD which was increased or normal, and those who had FMD decreased, you can see the difference that this chart starts parting at 6 months. If the FMD is decreased, you have higher chances of a vascular event. And ladies and gentlemen, watch out. There is a study coming from MISA. It's called the Masala study, which looks at ethnic South Asians, multi-ethnic study of South Asians. And you will see the data right there. So there is hope of this huge burden of disease that can be mentioned. About carotid ultrasound, I've been interested in for many, many years. Intima-medial thickness, we have now got data, it can even give you vascular. This at least gives you the handle of one thing, that the patient is already atherosclerotic, right? His LDL, his non-HDL cholesterol is 100 or 120. Here is the person who's likely to get a vascular event. Now, the beauty is that there's somebody who did a study in Manhattan, and he found that if there was a plaque above 5 millimeters above the internal carotid artery, this person definitely had a chance of getting a, because if you have a plaque, if you have increased intermedial thickness, you're going to have blockages in the arteries as well. And the other offshoot of this is that you can look at the vascular age of the patient. So here is the gentleman who's six-pack abs, who's exercising. Actually, he's only 38 years old because his intermedial thickness is less than 0.6. And then you see this, and this is a typical Indian patient, never exercised, heavy on cigarette smoking, alcohol flows every evening, and there is no doubt why we get, even our resident don't bat an eyelid when he gets an anterior wall MI at age 35. The first thing he does is he tells Dr. Kapoor, sir, I'm taking the patient to the lab. So there is incremental value of atherosclerosis imaging, no doubt about it. And people are using it. This is a famous bioimage study, and I'm not going into details of that, but by simply atherosclerotic subclinical, you can upgrade or downgrade people. The point is, you know the low risk individuals, you know the high risk individuals. It is the intermediate risk individuals that you have to look at. And they form the main bulk of the society, that they're not falling into any group. And this bioimage study definitely demonstrated that you can, with carotid femoral intermedial thickness, you can actually upgrade these people. We did the study with Dr. Valentine Fuster, whom you know is the editor of JACC, and we took this in an area which is in the news for all the wrong reasons for the last 20 days in Sirsa, and we did rapid screening for subclinical atherosclerosis. This is called the HAPPY study, Heart Attack Prevention Program for You, and we only did carotid intermedial thickness. That was the only thing permissible because the state has got very strict rules about P and DT. We said we are not even using a 2.5 megahertz transducer. This is 7.5, and this is on the carotids. So Dr. Fuster and all were very happy, and this data was published in Global Heart in the year 2013. So carotid femoral ultrasound, you can use it, and you can see those who have intermedial thickness have say 8.5%, 6% death rates. If they have carotid as well, 39.5, and if they have all three. So you can actually pick up patients at that level. Doctor, I'll just take 2 minutes more.
Please.
The other thing that we use very routinely is the pulse wave velocity, which gives you an idea of the central aortic pressure, which gives you an idea about the brachial ankle pulse wave velocity, which is very important, and diabetologists routinely use it for early detection of coronary artery disease, and also will tell you about peripheral vascular disease. If the person has coronary artery disease, he may have peripheral vascular disease also. So this is a simple test that we have developed. This is done by Periscope. In our institution, we have huge data. And just put these things together. See the patient's profile, look at the patient's history, look at intermedial thickness, carotid femoral, pulse wave velocity, and you know where you're going. And of course, coronary artery calcium score seals it all. If you have seen cardiovascular research just 3 weeks back, the journal, it very clearly says that there is close correlation between coronary artery disease, volume of calcium score, and CAD. So CS is very important. We have our own data. So this is not based on data from the US or anywhere. This is our own data. So which says that you can, both intermedial thickness, pulse wave velocity, and calcium score can be used for early detection, for preemption and prevention of cardiac disease. So the relationship with coronary calcium is very clear. Then we did a study, and we found that there was a clear correlation between coronary artery disease, coronary atherosclerosis, and so ladies and gentlemen, the point is people say, oh, there is no data available. There is data available. SCORE India tells you the normative data of coronary, of CIMT from age 30 to age 70. There is data existing on pulse wave velocity, and there is data on coronary calcium. So Indian data is available. We just have to read it. That is about all. Normative data is available. So what we infer from this is that please don't worry about the high risk and the low risk. We all know about it. It's the intermediate risk patients who, if they have positivity in subclinical atherosclerosis, then here is your target, just like the HOPE-3 study. This is the target, that these are the people who need to be treated. So you can see these are the people in the intermediate risk people. If they have IMT which is elevated, they go to high risk, and then you can take it from there. So I will end with this. This is a lady who's done a lot of work actually in TAVI. But she came up with this article, which I don't know how many times I've read it, but I think I'll share it with you. Curing atherosclerosis should be the next major cardiovascular prevention goal. Until and unless we think of atherosclerosis, we'll never be able to prevent it. The patient comes with chest pain, strongly positive TMT, we put him through an LED stent. That's not prevention. Yeah, you have to look at atherosclerosis. And now there are ways and means of doing it. So Dr. Kapoor, thank you very much. This is visionary that in this august audience of people who are so much interested in surgery and intervention, you've actually included this topic, and I thank you for that. Thank you very much, ladies and gentlemen.
Well, thank you, Dr. Kasliwal. I think this was the most emphatic statement, that we have to look at the coronary atherosclerosis prevention rather than just preventing the MIs or anginas. So I think it was a wonderful, talk by Dr. Kasliwal, and I believe that he's king of preventive cardiology. He has so many research papers in his name on carotid intimal medial thickness and brachial artery flow velocities. I think it's tremendous. So can I ask my panel, do you want something to add or some questions? Dr. Jha, Pramod? Any questions from the audience on this? So how many, I believe, how many in your practice are doing these parameters, carotid intimal medial thickness and flow velocities, to check whether they are the high-risk candidates for the future events. Yeah, Dr. Balraj.
How?
Pardon?
Periscope is very authentic, sir. Because in patients with systemic hypertension, just don't be happy with just one brachial pressure. Of course, that will continue to be the gold standard. But if you can tell about the central aortic pressure, the central aortic pressure talks to the heart and the brain. Many people say, ये तो 60 गए 60 के ऊपर हो गए जाने बह के बह. It's all because of microinfarcts which come from the aorta and the arterial and the arterial stiffness. 1676, somebody said a man is as old as his arteries. Well, this is the way to actually note it. And many people who don't get treatment, whose blood pressures don't come down with ordinary treatment, they are because they've got stiff arteries. So then they become resistant hypertensive patients. But they are the ones who will get strokes and heart attacks.
Has Periscope really helped you in your clinical practice?
Oh, absolutely. We absolutely, sir. Because it is not only giving central aortic pressure, it is giving ankle brachial index, it is giving pulse wave velocity, and the European Heart Journal has actually brought out a special supplement on arterial stiffness.
Thank you.
Any other inputs?
Sir, I'm Dr. Rakesh Behel from Jammu.
Yes, sir.
So I just want to know if you are conducting any training courses on preventive cardiology in your institute.
Yes, sir, we are. Anybody you want to send, just send them down.
How long is the duration, sir?
No, for these techniques, we are just saying 4 weeks and no more. Because these people will be already well versed in clinical cardiology, so we just have to give them, and they'll stay with us and look at these techniques being done routinely.
Thank you, sir.
Thank you.
Thank you, Dr. Kasliwal. I think
Thank you very much, sir. Thank
with
you.
this we close this session, and let's give a big applaud to all the speakers and our panelists.